Hi, everybody. This is Matt. I want to say thanks so much for joining us today. And I just want to make sure that you guys can hear me all right. So if you will just chime in on the questions part of your control panel, and we'll get we'll get moving through this presentation. We're very excited to have our presenters today for how to effectively screen your referring physician network using NPI. This is a great topic we've heard a lot about, and just want to chime in with some experts here and share what we've learned and how to effectively implement this at your organization. So some faces you may recognize here: Mike Rosen, our fearless leader and co-founder at Provider Trust, and Donna Thiel, who had together they have plenty of experience in the law side of compliance, and also Donna has 30 plus years experience in the long-term care world and being a compliance officer at a top provider organization. So you've got the right people here today, and I just want to say thanks again for joining us and responding to those emails. A couple things before we get going. You will receive a copy of this presentation. It's actually located in your handouts tab on your control panel. So you have that now, but you'll also receive that later to share with whoever you want, and you will receive a recording as well as your CEU certificate. So be on the lookout for that this afternoon. That will all come around 3 or 4 Eastern time. So expect that today. And a little bit about us, if you don't know, or if this is your first webinar, we are a software as a service company located here in Nashville, Tennessee, but we really love the education side of healthcare, and really getting together some of the thought leaders in the industry and listening to you guys, and really trying to bring relevant and timely information to you to help you grow and succeed. So we are glad that you're here with us today, and we hope that you continue to join, learn, and grow at your organization by utilizing some of the resources we've put together. These are some that are coming up. So our webinars are good for CEUs. On the health plan side, but also provider side, it may be relevant to you and your organization. But we have another webinar April 10th, the next one April 24th, and the next one on May 15th. So you can see a little bit about those topics. If you have registered today, you will get promotion from me for these webinars and get chances to sign up starting about a week before the actual presentation. So just something to be on the lookout here to schedule over the next couple months. So today's agenda, we will cover referring physicians and the law, healthcare population monitoring, using NPIs to complete your data, and finally, what you can take away and implement at your organization in terms of next steps. So before we really get started, we are curious to know, what do you call, or how do you refer to your non-employed physician? So we're going to have a couple polls today. This is the first one, and we're just curious of what you might say here. So we'll give that about 15 seconds for everyone to reply, and then we'll start moving on. Okay, we'll close that out and share so you guys can see who all is on the line. It makes sense that the majority of you would call them referring physicians, but we have heard of referring physicians referred to in these other ways. So if you did choose other, we'd be interested in knowing what you do call them, just so we can get better at our vocabulary and just know who's on the line and who we're talking to here. But with that, I will hand it over to Mike Rosen to take us through the first section of today's presentation.
Thanks, Matt. Good morning or afternoon to everyone. Hope you're having a great start to the spring. It's beautiful here in Nashville today. I thought it was interesting the poll answers that were provided. Obviously, I think it gives a survey across the people that are attending today's session that come both from the provider world, some from the post-acute versus the acute side. You have some health plan, obviously, people involving with the credentialing side. So I think we have a good mix across the board, and we'll make sure that we, for today's purposes, we will call everything based on referring physicians, but please know it would be the same definition, if you will, that you use based on your vertical within the industry. Let's talk a little bit about the law. We put into parentheses referring because people do call it different things based on the vertical that you're in, but overall the law is the same no matter what part or prong of the healthcare sector that you're in. So we can go to the special advisory bulletin that the OIG issued in May of 2013. It is really the most recent and really provides a lot more detail, which had been missing since the 1999 bulletin involving exclusions. So it's pretty instructive. If you haven't taken a look at it, we will provide you a link shortly, and I would suggest that you do so. And if you haven't done so in a while, it's a good refresher. But in essence, the OIG wanted to make it very clear in the May bulletin of 2013, what is the scope, frequency, and to whom does it apply when we're talking about either, quote, employees or contractors. That's very clear, has been always the basis for which the LEIE was formed. But then it gets a lot deeper, and long story short, it does in fact include those who refer, furnish, or prescribe services. So let's talk a little bit more about that. These are quotes from the actual statute, the law, and or the advisory bulletin. And in particular, exclusion statute, generally speaking, just identifies a person, quote unquote, but a person, when you look at the definition inside the statute, includes either an individual or an entity. So let's start there. When you dig a little deeper, the term provider within the statute, and as the OIG interprets, is used much more broadly, and it talks about providers, suppliers, manufacturers, drug plan sponsors, managed care entities, and quote, those who indirectly or directly furnish, arrange, or pay for items or services. That is a very broad definition. And as we'll see on the next slide, specifically does address and cover referring physicians. So if that is news to you, we're happy that we're the ones to be able to tell you so. If that is a surprise to you, so I think it surprised a lot of people when it first was really pinpointed in this bulletin, but it is well known and established that the OIG does hold you responsible in whatever vertical you may be in, whatever you would call in your nomenclature or referring physician, that provider can refer a patient to a non-excluded provider, but only if that excluded individual, in this case the referring physician, him or herself does not furnish, order, or prescribe any services for that referred patient, and that non-excluded provider for whom receives the referral is the only one treating the patient, and he or she independently bills the system. So what does that mean? First of all, we highlight that because that is a very difficult several prongs to meet. In other words, it's a very limited and narrow definition, and when an excluded provider can refer services to your system, hospital, or facility, and you can then lawfully take that referral. So it's very limited, and we're going to come back and address that in a minute. If, however, any of the items that are serviced or furnished at the medical direction or on the prescription of the excluded person, then they are not allowed, you are not allowed to receive it nor bill any of the CMS programs, et cetera, probably under your contracts, any of the health plans that you've contracted with, because you knew or should have known that that person was excluded. So what is all this saying? Let's take an example of a referring physician in a rural community. So say that this referring physician does not have privileges, is not otherwise credentialed by your organization, and yet they find a patient that needs services at your hospital or your surgery center or dialysis clinic. What this is saying is the fact that that physician is excluded in and of itself does not prevent you from receiving that patient, as long as that is the end of the rope for that physician. From that point forward, the referring physician has nothing to do, is not granted privileges, is not allowed to order services, x-rays, prescribe, furnish any type of services. They're just saying, take my patient. He or she is really sick. Although I'm excluded, and you're supposed to check that, I'm out, I'm done. I have nothing left with this patient. That's okay. But that's not normally what happens. What normally happens is that provider who is excluded, the referring physician, provides services and has some relationship or continues down the continuum of care for that provider in your facility. And that's what can get you into trouble. So I want to make that very clear, that it is a limited exception where they can at least refer them, but they got to step out of the picture completely and get no remuneration at all for these services. So if you have questions, by the way, please feel free to submit them and we will address them at the end of today's session. So a quick refresher, why is this important? Why should you care? And did you even know that the referring physician can get your organization into trouble? Well, that's because the OIG and all of the related guidance is very clear. If you happen to do business with, contract with, and or allow an excluded provider, either an individual or an entity, to furnish, prescribe, or in any way, shape, or form be involved in the billing of services, that is what is exactly prohibited by the law. And the OIG is really telling all healthcare organizations, do not hire or do business with excluded or sanctioned individuals, and that moves down or up the ladder based on where that referral may actually have come from, if they continue to provide services beyond the referral. So this can have a real big impact on you, especially if you're taking referrals from an outside of the state provider. Say, for example, if somebody is visiting the state of Florida, they're visiting their mom and dad who are in a nursing home, or they're vacationing, and they run into problems, and they call their doctor back in Nebraska and say, I think I've got X or Y, I've stepped on a fish and I've got some crazy fever and I need to go to the hospital, and that the referring physician is now their home doctor in Nebraska, for whom you have no relationship. You don't know anything about them. Well, you're going to need to know if after that person referred them to your hospital, are they out? Are they done? And that's it. They just say, go to the hospital. You're okay there. If they say, go to the hospital, when you're there, I'm going to order this service for you. We're going to get coordinated with care, and I'm involved. You need to know whether that referring physician in Nebraska is excluded. So that's the quick refresher. There are now 44 exclusion sources that you need to be concerned with. Of course, the OIG LEIE is the big one, but SAM also is one that you should be searching and can affect a sanctioned provider and or have other related matters that you need to be aware of. That's the old GSA list. And then there are today 42 state Medicaid exclusion lists that would be best practice to search, especially if you are providing services across the country in multiple states, and or like in Tennessee and bordered by 8 states surrounding, for which that person's exclusion could really come into play. So some quick stats before I turn it over to Donna to get into the meat of this. I don't know if you are aware, but the OIG database was audited by CMS, and they found that up to 2/3 of the state Medicaid exclusions, so coming from one of those 42 state Medicaid exclusion lists, are not reported or even found on the OIG. And there's lots of reasons why, but mostly it's because states are not good at reporting as they are supposed to up to the OIG when they take an action, so that the OIG can determine if it's mandatory or permissive and add it. So that's a problem, that 2/3 of those that do exist are never getting to the OIG if you're relying on the OIG to do everything for you. Now, also, on average, it takes 173 days for that state exclusion to reach the OIG, That's based on our analysis of all state exclusions, looking to see which of those are reported up to the OIG and what is the average. By law, it's supposed to be 30 days. The Medicaid fraud control units have agreed in order to receive funding to report all actions to the OIG within 30 days, and then the OIG should decide whether to add it to their list. That's not happening. On average, it's actually 173. And then we're going to talk specifically about what's the best way to search for an excluded provider and what data set. Well, obviously, I say obviously, hopefully it is obvious that in order to verify an exclusion at the OIG, you need a social security number. That is the only way to take a common name or a name with multiple John Smith and determine which of those is yours, is to have the social. But you may not have and probably will never get a social on a referring physician. They're not your employee. You don't have that paperwork and they're not going to give it to you. So the other identifiers, and the next best one would be the NPI. However, did you know that only less than 5,000 of the 70,000 OIG excluded records contain an NPI? So the OIG itself is missing 90% or does not contain an NPI on 90% of the people that they've excluded. So that presents a real problem that we want to address today on how to search, though, and make sure you're not doing business with an excluded referring physician. So I would like to wrap up this section by suggesting to you there are really 4 things that best practice would tell you wherever these responsibilities lie within your organization. It could be combined between credentialing and HR, could be HR and compliance, could be all within one area. But when you're talking about non-employed physicians, what we would call referring physicians, to avoid any of these fines and penalties, you need to know, are they licensed and without restrictions on that license at the time that they're referring. You might want to then check within, is that a credentialed, privileged, or employed physician, obviously. Are they excluded, which we've just talked about. And now we have a CMS preclusion list that needs to be an added service that you need to search starting April 1st. And then also, does that physician, in case he or she is going to prescribe, do they have a valid DEA registration? Those are things that somebody in the organization there needs to know before allowing that person to furnish, prescribe, or otherwise provide services. Now, other issues, according to the May 2013 Bulletin from the OIG, in footnote 10 says some excluded practitioners will have valid licenses or DEA numbers, but do not feel or don't get comfortable to know that that means they're not excluded. So in other words, you can't say, well, gosh, we checked their license and they had a valid DEA. What else did you want me to do? Well, very specifically, you also have to search to make sure that they're not excluded, because it will make any of their services not eligible for payments. So the last slide here before moving on is a reminder of the fines and penalties. I think it's important to note that everyone thinks of this as a up to $10,000 per item furnished or claimed on a billing. But actually, there was a statutory increase passed under an Inflation and Adjustment Act that actually takes it up to almost $20,000. And that is statutorily going up on an annual basis based on cost of living. So it's really closer to $20,000 per item that you claim. And the key word there is claim. You don't actually have to be reimbursed, and they can actually deny based on the fact that CMS knows that person's excluded. Just the submission of the claim is all it takes to be held liable for fines and penalties. Then they'll treble those damages, that's 3 times the amount, as punitive, because you're instructed not to hire someone and or contract with or accept a referring physician referral from an excluded provider. So this is very costly. It's also something that can be monitored, and we're going to talk about how to do so when you don't have a social security number, how to get around that. Donna, I'll turn it over to you.
Thanks, Mike. Appreciate that. Good afternoon, everyone, or good morning, as Mike said, and thank you again for joining us on another journey through some monitoring. So, Matt, if you wouldn't mind, let's go to the next slide. So as we start talking about monitoring these, referred physicians or non-employees, as we talk about it, it's hard to think about where do we begin. This population is really difficult for us on the provider side, right? Trying to figure out where all that data is and who are these people. So in my mind, the first place that we would start would really be looking within our organization to define who are these practitioners, and really it's greater than just physicians, right? It could be nurse practitioners or physician assistants as well. So really thinking about where are they, who are they within our organization, and depending on the volume of healthcare services that you provide, it might be all over the company. So really thinking about who are these people? Where are they located within your organization, right? Different lines of businesses. Are there different departments that they participate in? Are they only in certain states? Maybe you're a organization that's in multiple states, but maybe only in one particular state you have the situation. So again, I would start looking at this as who are these people? So let's look at what would maybe be the second step. So now we know who these folks are, but now who kind of, quote, owns that tracking of this population? So when I mean tracking, it's like who's gathering the information? When they're coming into our organization, what information are we collecting, and who owns that? Is it different people in different facilities, or is it different people in each state? Is it different people in the hospital? Who are all these people that have to track this information? And then are we really gathering the correct information? Is it consistent across each of these different providers? Do we really have sufficient information to even begin an exclusion monitoring process? So the third step that we might consider is, where is this information? So when we think about it, right, these are non-employed practitioners, physicians, so they're not sitting in our payroll system. So where would we capture or store that information? Oftentimes in our billing systems, we would have the NPI number along with the physician, because in order to generate the claim, we would have to use that NPI number. Some of our systems would potentially collect that information in our electronic health record or EMR. So you'd be looking potentially with your clinical folks, who's overseeing the EMR. Maybe you have a contract database. Now, these physicians, these practitioners aren't contracted with us, but again, not knowing how you collect the information, don't lose sight of that. AP might be a system. Again, we're probably not paying these practitioners, so might not be in the AP system, but another place to ask. And maybe there's other systems that I haven't even thought about. But when I look at it, probably the two primary places that I would begin to look, and the people that I'd be partnering with, would be whoever oversees my billing system and my EMR. Those would be the two places that I would begin to try to find information about these practitioners and acquiring their NPI numbers. So for step 4, now it's really, do I have enough? Do I have unique identifiers? We talked about Social Security numbers, right? For these practitioners that are employed, it's pretty difficult for them, for us to think that they would possibly give us a Social Security number. Realistically, it's the NPI number that we would be focusing on. It's possible that you would have a tax ID number or an EIN number, but again, you're not paying these practitioners. So most likely, there's only one unique identifier that you would be collecting on these non-employed practitioners. So then what's next? So how do we begin? What are the considerations that we need to take to look at these non-employees? So I would ask myself, like, if I'm trying to think about how am I going to start monitoring them, I would ask myself, does this list change routinely? Is it, let's just say in a nursing home environment, I have attending physicians, and I might have 10 or 15 attending physicians, and I would ask myself, am I adding physicians on a routine basis? Does that list stay relatively static? But maybe in a hospital setting, I have referring physicians coming every day, every week from all over. So maybe that list is changing pretty quickly. So then I would have to think about, okay, so how do I stay on top of that list as it's ever changing. And then, of course, the question of, do I have enough information? Again, do I just have the name? Does my system only have the name in it? Or am I lucky enough to have captured the NPI number? And really, the question isn't, did I capture it, but can I get the data out of whatever system that's housing it? So really partnering with probably your IT folks, right? Really understanding how to capture not just the name of all of these practitioners, but that unique identifier in order to allow me to take the next step of verification. So then the question is, how often do I monitor? This is really a question that I think you have to put some real thought into it. We know that the OIG says to us that they update the LEIE list on a monthly basis. And so as providers, we would really never have an excuse that we didn't know if someone was on the exclusion list, less frequently than once a month, because they're giving us the list once a month. But when you're asking yourself that question about whether the list is changing frequently, you might say, well, my list doesn't change that often, so maybe I think quarterly is sufficient. Or annually. I've never done it in the past before, so I'm going to try doing it one time a year, and let's just see what the results are. So really thinking about your risk tolerance in your organization and how readily accessible that information is for you to get as to how frequently you should monitor it. And then the really big question, Mike raised the point of, right, it's a problem when we submit a claim for one of these practitioners. So then you could ask yourself, wow, do I have the ability to monitor these practitioners before I submit a claim? So what's your internal process for getting a new referred provider or an attending physician or these non-employed practitioners into my system? So what's the communication flow? So I'm getting this information, I'm putting it into my billing system, or I'm putting it into my EMR system. What kind of check are you doing before you submit that claim? Or are those two processes completely separate, and I'm generating the claim and I'm running any sort of exclusion monitoring out of the compliance department that's not really looking at on a day-to-day basis, right, whether this claim has or hasn't billed yet for that practitioner. So I think there's an opportunity to consider monitoring these practitioners before you submit a claim, but recognize that that is probably a pretty important discussion and conversation that you're going to have within your internal team as to how the information flows before you can make that decision. So here's another polling question. So as we're talking about the challenges of monitoring these folks, curious for all of our audience, have you monitored your non-employed practitioners? Options, as you can see, are yes, as part of the onboarding or credentialing process. Yep, I do it monthly. I do it, but routinely, but less than monthly. Or no, I haven't done it yet. Or perhaps you're not sure because it's just not an area that falls under your area of responsibility. So Matt's going to leave that poll open for another couple of seconds while everybody's getting your answers in. Thank you for sharing. And Matt, let's go ahead and display the results. So it looks like about 25%, about a quarter of us, are monitoring as part of our onboarding or credentialing process. 38% are doing it on a monthly basis. Congratulations, that is fantastic. 5% are doing it, but a little bit less frequently. 18% aren't monitoring, and then another 13% of us aren't quite sure what's going on. So certainly kind of all over the across the board answers, and I think speaks to the challenge of monitoring this population. So let's talk a little bit more about the NPIs and how that can kind of complete your data analysis. As Mike mentioned, or I guess he didn't mention, but in the LEIE list, for those of you who download the database, the OIG doesn't give us those unique identifiers, the Social Security numbers or the TINs or NPI numbers. All of that information has to be manually keyed in after you find a potential match. So I know for me, way back when I first started looking at the the LEIE and this whole OIG process, I just assumed that the downloadable database incorporated those identifiers because I knew that when I logged onto, or went to the OIG website, I could key that in. So now, obviously, we all know that that information isn't available in the downloadable database. Let's go to the next slide, Matt. So how does the NPI help us kind of fill that gap? So as we just said, many of these populations, right, the data is incomplete or insufficient. So as compliance professionals, we have a hard time getting that information for our non-employed physicians. I can remember back when the NPI number first came out, when we all had to fill out, go on to the site and get an NPI number, and working with our medical directors, those contracted physicians, trying to get information from them, and initially trying to get social security numbers, and then trying to convince them that NPI numbers were okay, and then having to go through the whole process of actually sending them regulatory information to show that we had to have that information in order to generate claims. It's quite a process to convince people. I think today, perhaps it's getting a little bit less difficult, but really is oftentimes difficult for us to gather that information. And we know that if the data isn't present, the NPI number is a unique ID. So it helps us kind of fill that gap when other government databases maybe don't have it. So let's go on to the next slide, Matt. So the NPI number, in our minds, is kind of the core of being able to monitor these non-employed practitioners. So we know the NPI number, right? There's a name, they have credentials affiliated with their NPI number. For our health plans, the provider directories utilize the NPI number. You can use the NPI number to share information, and we can use the NPI in certain cases for sanctions and exclusions. So it really becomes the core of us being able to do all sorts of different things relative to this group of practitioners. So who has an NPI? I feel like when I was going through this sequence, we probably should have put this way back when and earlier in this presentation, but as just a refresher, right, who has an NPI number? We know that any healthcare provider or supplier who bills Medicare for services, right? So traditionally, a type 1 provider are the individual practitioners, physicians, dentists, physical therapists in some situations, right? Those practitioners. And then type 2 are the organizations, so a hospital or a physician group. Nursing homes each have their own NPI numbers. So there can be two different types of NPI numbers that are affiliated with different billing entities. So where's the NPI number published? We all know that, so I always called it NEPS. I know other people in my organization call it NPES, but it's the National Plan and Provider Enumeration System. It's administered by CMS. You go in, you fill out all sorts of information. You have to tell them your Medicare numbers and Medicaid numbers and the type of practitioner you are. You fill all that out, and then you're issued an NPI number. And then for those of us who need to go out and find NPI numbers, there's an online site. You can go in, you can retrieve different pieces of information about the NPI, and you can actually download a list of all of the active NPI numbers that are out there. So let's look at a couple of case studies that we've been fortunate enough at Provider Trust to partner with our clients and do some exclusion monitoring and utilizing the NPI numbers that they have within their systems. So this first case study that we're going to look at is a regional health system who asked us to monitor their non-employed providers. They had about 5,600 providers, and this was a new client for us, and they were just onboarding this particular population. And so they had not previously, on a kind of a full-scale review, had not monitored this population in the past. They had a new compliance officer who was just joined the Provider Trust family, and she brought a new perspective to her organization. So they brought us their population, and the very first time that we monitored for exclusions, again, and exclusion monitoring is the OIG and all the SAM, and then all of those other 42 states. So right off the bat, we found that NPIs that they had in their system, 32 of them were inactive NPIs within their system. So that means that a practitioner that they had in their system, an affiliated NPI number with that practitioner was either not either accurate or it wasn't active, which creates a problem in and of itself, right? 2 of them we found weren't even valid NPI numbers at all. They weren't in the system. They didn't match any NPI number that was in the NEPS or NPES system. And then, unfortunately, we also found that there were 12 exclusions affiliated with those valid NPI numbers. So one thing that I don't think we've mentioned yet, at Provider Trust, one of the things that we've done is we've actually gone out and created links, if you will. We've what we call augmented our data, but we've been able to go out and connect exclusions with NPI numbers. So our database is a little bit deeper, if you will, than what you can get right out of the OIG site. So we are helping our providers kind of bridge that gap and find and link providers when they only have an NPI number. So that's why this process was so important. So when all was said and done, of the 5,600 providers they had to deal with 46 providers that they needed to follow up on and try to figure out what was going on relative to either the NPI or exclusion.
Donna,
let's look at another.
To add into something we learned at one of the more recent HCCA, actually managed care conferences. So I think a theme that everyone who's been to any of those conferences could agree in the last 2 years at least, the OIG is proactively working and has hired some data analysts, data scientists on their team that go in and do, no surprise, proactive audits. So since they see every claim submitted, CMS sees it, they're sharing it with the OIG, and then the OIG is conducting searches like we're just outlining for you here. Which of those claims had a valid NPI? I mean, everyone has access to the same public record data. And this is how your organization shows up on the radar screen or an unannounced visit by an OIG investigator or auditor. And so there's really no hiding this information, because all of any information on a prescription involving a pharmacist or a prescriber, referring physician, has an NPI. And it's very easy for not only you, but these data scientists to go through and bring to the OIG those companies that need to explain why they're submitting claims for a person whose NPI number is not valid, it's inactive, or even worse, very clearly associated with an excluded provider. So it is if you think that they're a bureaucratic and large red tape organization that isn't using data provided to and that they haven't access to through other organizations like CMS, you're wrong. And they're very clearly going after organizations based on data that they know you have and they also have.
Thanks, Mike. Excellent point. Absolutely. So here is an example of a particular exclusion. So on the left column is information that the client provided to us. And in the center column is a Maryland state Medicaid exclusion. You'll notice that the name is the same, but the address is different. What we were able to do, because the client gave us the NPI number, we were able to identify an exclusion matching the Maryland Medicaid exclusion because of the NPI number that matched. So another example is very similar. This one is a Pennsylvania state Medicaid exclusion. Now you'll notice on the left side again, the client provided us with a particular set of information. And then in the Pennsylvania State Medicaid, they had less information, and again, no NPI number, but we were able to supplement the information and identify the exclusion. On this one, I might just point out that this was a client who we were working with and really helping them look at the claims information, and they had already billed for that particular provider about $14,000, almost $15,000 worth of claims. So we were working with them to try to help them look at a pre-claim review process, and we're going through and looking at all of their information. So again, you'll notice, I guess one other thing to point out is that this practitioner was in Texas, and the information that they provided was Texas, but the exclusion was in the state of Pennsylvania. Mike, anything you want to add to those couple examples?
No, I will say that this is not atypical from what we find. Providers that have problems pack up and leave and hope that you're not going backwards on their history and historical to find out where they were. But that record does exist in the state in which they came from. And so that is not to say that all moving providers or any of the physicians that are hospitalists and may move around are bad people, but it does provide a way, at least on the practitioner side, to find people who are trying to stay one or two steps ahead of a disciplinary board, a DEA registration, revocation, or some other matter that sits somewhere else and is going to affect you if you're not searching. I thought your point earlier, and we've had a couple of questions in this regard, is, so am I supposed to monitor all my referring physicians, on an ongoing basis? Because the OIG is updating their list monthly. And that is, as Donna, you pointed out, a really tough decision. It's a risk analysis question for your organization. You don't know at this point how often that patient or that provider is going to refer a patient. If it's routine and they're regularly, certainly an attending physician in a long-term care facility, and or somebody that is privileged, yes, they should be monitored on a monthly basis, because it would be disruptive for you to miss a month and find out that in fact that you shouldn't have received that referral. If it's a one-time referral and you don't even know this provider at the time of receipt of the patient or the services being requested or furnished or prescribed, it would be best practice to do it then. But then you have to decide, this may be the only time I hear from that physician or that nurse practitioner or whomever it is. So if they're not regularly performing those referrals or ordering services or furnishing things, then you could get away with not doing it on a monthly basis, as long as you have a way to have a check and balance to know that when it's the first time or it's been a lull and now they've resurfaced and sent somebody in, that you have a way to detect that and search at that time. It all has to do with making sure at the time services are ordered, prescribed, or furnished, and you're going to submit a claim, that at that point you've done some analysis on this exclusion. And I think the point of the NPI being the best way to determine, you're going to be able to ask 100% of the time a non-employed referring physician for their NPI without any qualms. If they give you qualms in providing their NPI, you probably shouldn't be doing business with them in the first place. So the NPI is not some secret like a Social Security number is, protected class. It's issued through the NPES service for any practitioner who qualifies, and they're going to have to put it on prescriptions. They're going to have to put it when ordering through pharmacies. I mean, it's not as protected, obviously, as a social. So let's talk about some key takeaways, and then we can address a few of the questions that have come in. So, many of the healthcare populations for these non-employed physicians, you're presented with a difficulty because A, do you monitor if you don't know that they're not regularly referring? And B, what do you do when you know you're not going to have the key identifier, the Social Security number that you really need? Well, that's where the NPI comes into play. Now, if you're searching just the OIG list, and certainly if you're searching state lists, they very rarely have an NPI. Most state lists do not contain an NPI number. Only 10% of the OIG's records contain an NPI. So you're still potentially missing 90% of comfort level without that Social Security number if you have an NPI. What companies that are really thinking ahead of it, and I consider us one of those, we're augmenting our data, as Donna showed you in those two examples, to grab the NPIs of all excluded providers. So even though the OIG doesn't have it, that doesn't mean it's not available to be cross-referenced and have, so that as many of the exclusions that exist for which an NPI can be identified with provider can be enhanced and augmented databases like we do here at Provider Trust. That gives you the added comfort that you're able to take an NPI, literally an NPI, and determine if that number is associated with the excluded person. We will be rolling out shortly an enhancement, and on our website, the ability to search that, and that will give you the comfort level to know that you can tell whether that NPI number is in fact associated with the excluded provider. So two, that NPI number is the unique identifier that you really shouldn't have an issue or qualm in getting, and you need to be asking for, and wherever that may be stored, your billing system, your EMR system, go find it, because that's what's going to be needed to search and get a comfort level that that referring physician or provider is not excluded. The augmentation tool that I just outlined for you will significantly reduce and give you that extra protection on the missing numbers that the OIG list does not contain. That's 90% of their records, doesn't have one. There are some proactive searches that you can do, but you're going to have to decide how to identify it and whether it's someone that you either are monitoring or haven't, and it's a new or referral that hasn't come in a long time, to be able to make sure that claim is not submitted for that excluded provider. And what processes does that put in, changes in your organization? So what next steps if we were in your shoes and this is new and or ability to check against what you're doing? Make sure you've identified where all your non-employee practitioner information is. Where is it, or where are they? They're probably in multiple places, and you need to know where they are, because that's an identifier you need to have. Determine if you have the ability to consolidate this into one type of receptacle and or place to then search for exclusions, because it probably does exist in multiple places in your organization. The frequency, that's for you to determine. The more regular they're referring, the more regular you should be monitoring. And for the one-offs, if you can catch it and do it at the time of that, then that's fine. That will meet the tenets of the law. Consider implementing really a pre-claim process, and certainly at the point in which somehow you're about to submit a claim, make sure you've got some way to know that person is not excluded at that point. And then we know that's difficult if determining how good your data is an issue you'd like to discuss. We can help you with that. We can do a data scrub and let you know what exposure you have. These following records don't have an NPI, but you could do that yourself and consider your risk of having to go and fill in that data. So these are sort of the next steps that we suggest you take as you look at your own processes. And if this is news to you that referring physicians are a problem, now's the time to put into place the right systems. So we have some questions that have come in, and I will, just a handful actually, but I will address them. So is the NPI number the same as the old UPIN number? For those of you who've been in healthcare a long time, you may remember it used to be called a UPIN. And the answer is yes. The NPI is the replacement for UPIN. So CMS stopped updating the UPIN records in 2007, and now have assigned everyone who had a UPIN an NPI number. So that is today the NPI is what you should be searching. Another question that came in, which is a good one, can a provider have more than one NPI? And the answer, surprisingly, is yes. And typically that's when you're involved in a group practice or a group setting in which you, the individual provider, may have an NPI, but so will your physician practice. And therefore, you need to know if that entity is excluded in some cases as well, or in addition to the individual. So that's true for labs and pharmacies in particular, or physician practices. So good question. Last question is, does the NPI number expire? And it does not. It can be revoked by NPPS, but it does not expire. So you have, once it's assigned to the individual, but knowing whether or not it's a valid number and that individual separately is properly licensed and not excluded are additional things that you're going to need to search. So good questions on the NPI itself. And then we have a question here that came in just a few seconds ago. Are you saying that the prohibition against hiring or contracting with excluded persons or entities includes persons or entities that are excluded on a state Medicaid list, but not on the OIG list, or just that it's best practice to check across state lines? So that is going to depend on your organization. Is that provider providing services in a state in which they are excluded? Or say, for instance, they're an RN and they have privileges and are part of the national practitioner across state lines, and they're traveling into that state. That would be a problem. If you are a national provider, and let's look at even telemedicine. Let's say you're providing telemedicine services, and the phone call comes in, and you're receiving that request for some type of care in Arizona, but that person's calling from Nebraska. There are very distinct laws on whether or not the state in which you are receiving the call from or making the call to are a factor. So the answer is, best practice clearly is to search not just the state in which that practitioner is practicing, but really all 42 of the other states, so that you don't run into any issue of providing service to a practitioner or to a patient to whom that you can't bill that state Medicaid exclusion list.
Great. Thank you,
So
Mike. Oh, sorry. Go ahead, Donna.
Sorry, I just want to clarify. Just so that particular question, are you saying that the prohibition against hiring or contracting with excluded persons includes persons excluded on a state Medicaid list? Just that half of the question, the answer would be yes.
Yes.
Right. So best practice is to check all the states, but regardless, if you're in one state, if someone is excluded in that one state, you cannot hire or contract with that person. So I just wanted to be clear that it is best practice to check all the states, but no matter what, the answer would be yes, for sure. You need to be checking the state in which you're operating to make sure someone's not excluded on that list, in addition to the OIG and the SAM.
That's right.
Sorry, I just wanted to just clarify that part.
Thank you.
Great, thanks, Donna, and thank you everybody for being with us today. We know it's your time is valuable, and we really appreciate you spending your lunch hour with us. So with that, we'll start to wrap up. You will receive a recording of today's presentation, as well as a copy of the slides and your CEU certificate. If you have any questions or concerns, or just want to reach out with anything, please don't hesitate to just respond to that email, and I will make sure, if I can't answer it, that I will forward it to the correct person. So with that, Mike and Donna, thank you so much for being here today, and thank you for joining today's presentation, and we will see you next month.